Hello, everybody. I'm Pharmacist Michael, and today I have a very special guest, Dr. Stephen Reichbach, who is a anesthesiologist and a specialist in ketamine administration. And I'm going to ask him some questions about this and let him educate all of you in the uses of ketamine and why it is such an important drug. Welcome in, Dr. Reichbach. Thank you for taking the time to talk with us today.
My pleasure. Thank you so much for having me.
Okay, so let's start with who is a good candidate for ketamine?
So there's a couple of classes of patients that we treat with ketamine. And the first is patients with certain chronic neuropathic pain conditions or pain syndromes. The second class of patients that we're treating ketamine with is patients who have certain mood disorders, more specifically major depression, treatment-resistant depression, PTSD, anxiety disorders. Ketamine for either of those classes of patients is not usually the first line of treatment. So the majority of patients that we're treating have generally been to pain management or been to psychiatrists and therapists. They've been on numerous medications. In more extreme cases, from a mental health perspective, patients that we're seeing have been through TMS or magnetic stimulation therapy, and in even more extreme cases, electroconvulsive therapy. So the patients that we're seeing are more or less, they've been classified as treatment resistant in many respects. And so whether they're on medications now or they've been taken off medications, they've stopped medications, the patients that we're treating are really patients that have not had success being treated with other modalities of therapy.
Okay, so if somebody comes to you and they're telling you that their pain medications aren't working, how do you know that ketamine is a good choice?
Okay, so ketamine itself is it's an anesthetic. It was invented about 60 years ago. It's a synthetic drug. It is actually on the World Health Organization's list of 5 necessary medications, 5 of the most necessary medications. It's a fantastic anesthetic, analgesic in the short term. And it's used widely in operating rooms and surgery centers and even on the battlefield to treat people who've been through traumas. So basically, ketamine, when we're treating these patients, especially from a pain perspective, not all chronic pain patients are going to respond well to ketamine. The patients that we're treating that seem to respond the best are patients who have conditions where there's a large central pain component to what they're struggling with, as opposed to a neuropathic pain, peripheral neuropathic pain syndrome. So we'll get calls from patients who they've been to pain management because they've got low back pain or they've got radicular pain from herniated discs or spinal stenosis. And what I tell them is that it's likely that ketamine is not going to be helpful long-term as far as the pain that they're struggling with. The patients and the initial studies that were done using ketamine for long-term pain relief were done on patients with a condition or a syndrome known as RSD, or reflex sympathetic dystrophy, which is now referred to as CRPS, or complex regional pain syndrome. Complex regional pain syndrome has a very large central component to the pain. And when I say central component, I mean that the pain emanates or originates in the central nervous system, the spinal cord or the brain, as opposed to a nerve injury or inflammation surrounding a peripheral nerve where the pain is then transmitted to the brain, and that's how the pain cycle goes. Patients who have central pain basically have pain that's way out of proportion to what can be pinpointed. So The patients that we see with large central pain components, typically they've had CAT scans and MRIs, they've had all kinds of lab work done, and still the degree of pain, the intensity of the pain is out of proportion to what anybody can put their finger on. They typically have been on the usual medications, opioids, certain antidepressants, which are used off-label for pain, nerve medications, Lyrica, gabapentin, muscle relaxants, and they're still struggling with this pain. And many of them have been through pain management and nerve blocks, and in more extreme cases, pain pumps and spinal cord stimulators. And yet the pain that they're dealing with is impacting their daily life, and they're looking for an alternative. And there are certain conditions that we know have a large central pain component. For instance, patients with CRPS, patients with certain types of headaches, migraine headaches, cluster headaches seem to respond very well to ketamine. Trigeminal neuralgias, to a large degree, respond very well to ketamine. Post-herpetic neuralgias or shingles seems to respond well, phantom limb pain. But for those patients that call me and they say, I've had 5 spine surgeries, the pain is worse than it's ever been, it was supposed to get better, I've had chronic pancreatitis, and is this something that can help? Quite honestly, my threshold to try ketamine on patients with those types of stories is really very low, because the downside is it's not going to help at all. But the potential upside is, if there is a larger central component to it than we know, they're going to probably get some significant pain relief longer term from these infusions. Now, ketamine itself is an amazing, a wonderful analgesic. It's stronger than morphine in the short term. It's in your system for about 12 hours. So generally, when patients go through these infusions, they don't walk out of the office in significant pain. The key is how they feel the following day when the ketamine's been completely metabolized, and we're going to get a better idea of how it's going to work longer term.
Okay, I'm getting a ton of questions in here from the people watching about different types of pain. Mm-hmm. There's a question about ovarian remnant syndrome and endometriosis with gastroparesis. Yeah. Spinal stenosis. There's a question about fibromyalgia. So to sort of just take them together and take them individually. Spinal stenosis, ketamine is not going to fix any structural issues or peripheral issues that may be responsible for chronic pain. We've treated patients, and like I said, sometimes I don't even know, and we will use a ketamine infusion as much as a diagnostic tool as a therapeutic tool in trying to figure out if it's something that can help. So if I'm not clear on what degree of their pain may be centrally mediated or what may be peripherally mediated, I may tell them and set the expectations, realistically, and say, there's a chance that this might not help at all. There's a chance that this may help you 20%. If you're happy with that expectation that you may get 20% relief, then I think it's probably worth trying. For a lot of these patients, it would be difficult for me to say that you're going to get 100% relief and it's going to last for weeks to months. There's a condition, as I said, known as CRPS, which is it's probably 200,000 people in the country are suffering from it. There's probably a whole lot more that haven't been diagnosed. It's a condition that goes underdiagnosed and is one of the conditions that responds extremely well to ketamine. And so the idea is to try to start treating it, diagnose it, and treat it sooner than later, because the longer it goes on untreated successfully, the harder and more intractable it becomes trying to help patients lower their pain level using ketamine or whatever other means later on. As to the audience members out there with those specific questions, again, it would depend on what
proportion or what degree of their pain is centrally mediated as opposed to peripherally mediated. Having said that, patients who have an initial injury or have an initial cause for their pain, peripherally mediated pain, very often may develop some central component to it as time goes on. The longer you're in pain, in chronic pain, your body sort of compensates and sort of senses a whole new normal. And the way that it responds is by increasing or proliferating the number of pain receptors that ketamine acts on in the brain, the connection between the spinal cord and the brain. And the more of these receptors that there are, lends itself to having more pain. And so it almost takes over a life of its own for a lot of patients with this chronic pain that's been going on for a period of time. So the goal really is to try to decrease the amount of that extra pain that they've developed, that central mediated pain that's out of proportion to what the original cause was.
Okay. So if somebody does decide they want to do this and they come to you, what are the side effects?
So ketamine itself it's a very safe drug in and of itself. It's very hemodynamically stable, which means that it does cause some increases in heart rate and blood pressure intrinsically. Very little in the way of respiratory depression, which most opioids and other sedatives and other types of pain medications seem to cause. And so it's a very safe drug. The main concern that I have when patients come to the office and start undergoing these infusions is the dissociative effect from ketamine. And I can tell you the majority of the patients that we treat find going through the experience extremely warm and nurturing and transformative, and they have clarity and they have all of their questions are answered. It's a very comfortable thing for them to go through. They typically will listen to music that they enjoy listening to. But having said that, there are a portion of patients, there's a subset of patients who don't want to have any mind-altering effect to the ketamine. They don't want to have any dissociation. More so patients that have been through some significant trauma. I think I just went off the screen there.
No, you're still here.
Okay, good.
I'm going to try to bring you up here. Can you move over to your left just a little bit?
Sure.
Perfect. Now they can see you better.
Okay.
Go ahead.
And so the patients who don't want to feel any loss of control or any of the mind-altering effects from the ketamine, they don't have to when they undergo these infusions, especially from a mental health perspective. There's a lot of misinformation out there, and if you listen to enough patient accounts, you'll hear people or patients who said, wow, I tripped my brains out. It was wonderful. I figured everything out. My depression is lifted, and that's wonderful. And I'm very happy to let patients that want to undergo the experience, they feel that they're getting something out of it, to let them go through it. But for those patients who are, they're concerned and they don't want to have any significant dissociation or loss of control, the science behind this is that they don't have to. So if I were to give a patient 50 milligrams of ketamine over 1 hour or over 2 hours, that experience for them is going to be completely different. Over 2 hours, they're going to feel more or less like they feel right now. And over 1 hour, they are going to have some mind-altering effect to it. For me, the ultimate outcome is going to be the same. It's that 50 milligrams of ketamine getting to the brain and sort of jump-starting these physical changes, or these hardwired changes in the mood centers of the brain that we're looking for. And that seems to correlate to an improvement in their mood, a lifting of their depression, lessening of their anxiety, and just a general sense of well-being.
Okay, so if do they have to be referred to you by their PCP?
They don't have to be referred to me by their PCP, but we do need them connected with a physician, whether it's a mental health care provider or a PCP who's prescribing medications, so that we can, get a firm diagnosis and get, a full list of their medications. And if I have any questions concerning any questions about their mental health status, I can contact somebody in that regard. There are certain conditions which would make or preclude ketamine from being used, contraindicated for patients who have been diagnosed, let's say, with schizophrenia and they're actively psychotic or delusional, patients who have been diagnosed with bipolar disease, and we treat a large number of patients who have been diagnosed with bipolar depression. But if they're in a hypomanic or a manic phase, that would not be a time to administer ketamine to them.
Okay. Daphne, Dr. Reichbach is an anesthesiologist. Okay, so I'm a patient. I come to you. I sit down to have my infusion. How is this going to go? What do I expect? Is there going to be a nurse with me the entire time? Are you going to be there the entire time?
Sure. So we have 4 individual infusion rooms with full monitoring, EKG, blood pressure cuff, pulse oximeter, which measures oxygenation, a reclining chair to make it as comfortable as possible. We have blankets and pillows so that patients they can be as comfortable as we can get them. We have cameras in the room, and we have call buttons in the room. Patients are welcome to bring a loved one with them, a friend with them, to sit with them. I can tell you it's a small office, and myself and Lolita, who's the registered nurse, are here at all times. And so the majority of patients prefer undergoing the infusions with the lights out and, sort of listening to music and zoning out and just kind of getting lost in themselves. For patients that, pretty much anything goes as far as what we can do to make them comfortable. So there are some patients that like having the room lights on. They want the door to the room open a little bit, and they want us checking on them fairly constantly, and we're happy to do that. It seems as they go through these series of infusions, though, that they sort of prefer to be on their own. They know what to expect, and that's kind of how we go about it. We have a continuous monitoring of the cameras. We can see all the patients in each and every room. If they need anything, they just simply press the button and it rings, and we all go to the room and see, if there's anything that we can do to help them.
Okay, Jennifer's asking if this is FDA approved.
So ketamine itself is approved as an anesthetic. The intravenous ketamine, the racemic ketamine that we use in these infusions, is not specifically FDA approved to treat mood disorders or even these pain conditions that we're treating. And this is part of the reason that this has been so difficult, trying to get insurance companies to cover or defray some of the costs of this.
Okay, so I want to switch gears just a second to depression.
Sure.
So one of the big advantages of ketamine is it works right away, right? You
Yes,
don't have to wait 2 weeks.
that's correct. We will typically do a series of 6 infusions. For the majority of patients, we try to do that within a 2-week time frame. 20 to 30% of patients will note a marked lifting of their mood, an improvement in their depressive symptoms, functional improvements after the first 1 or 2 infusions. So these physical changes, and this is how it's thought to work differently than the SSRIs and other classes of antidepressants and mood stabilizers and atypical antipsychotics, in that it's these physical changes that we're eliciting. We're not trying to increase or modulate serotonin, dopamine levels, norepinephrine levels. These are physical changes that seem to occur almost instantaneously to administering an intravenous ketamine infusion. So for sure, for the majority of young patients, it may take 2, 3, 4 infusions before we start to see a noticeable improvement. For older patients, it may be the 5th or 6th infusion. But we will know within that course of the first 6 infusions if a patient is going to respond to these infusions of ketamine.
So if somebody, let's say they've tried every antidepressant, they've tried ECT, they've done all this stuff, nothing works, ketamine does work for them.
Mm-hmm.
How often do they have to be treated? And you said it's hard to get the insurance to cover it. Is there any insurance that will cover it in those cases?
No. Well, yes and no. We have not heard of a lot of success stories as far as patients recouping any of the costs of this. Sometimes maybe they'll get 20% back, 30% back. We have patients from out of state. One most recently from Massachusetts who has Blue Cross Blue Shield from Massachusetts, and she was told that they were going to cover the entire cost of the treatment. So we're still waiting to see what transpires with that. But for the most part, I tell patients not to get their expectations up that this is going to get covered by their insurance. Under certain circumstances, depending on an individual policy or a certain group, certain insurance company, they may have some percentage of the costs reimbursed, but for the most part, really, the answer is no at this point in time.
Okay, because inpatient psychiatric hospitalizations is so much more expensive. Do you see this changing in the future?
I'm certainly hoping that it's changing. I mean, we had 2 calls today from one psychiatrist and one patient that were concerned about an increase in suicidality, and the next step was going to be, having them either Baker acted or having them voluntarily inpatient admission to try to deal with this, and they want to try ketamine before they go that route. And ketamine has been shown to be 85 to 90% effective in patients who are acutely suicidal, in quelling the suicidal thoughts and the suicidal ideations. So it can be a real game changer with respect to that, and in certain instances, avoiding a hospitalization for some of these patients.
Okay, here's a really specific question.
Mm-hmm.
Can it be used on an otherwise extremely healthy 80-year-old woman with post-herpetic neuropathy from shingles?
Absolutely. We see a large number of patients with shingles or post-herpetic neuropathy, and it works extremely well for a lot of those patients.
Okay, I'm getting a lot of questions in here about, is there somebody in Ohio? What if I'm in California?
Mm-hmm.
If they call you, would you be able to refer them to somebody, or would they need to make a trip to Florida, which wouldn't be the worst thing in my mind?
No, it is a destination spot, that's for sure. We have a large number of patients who do come from different parts of the country to the clinic here. They don't have to do that. There are reputable ketamine centers in a lot of areas in the country, and I'm certainly happy to help anybody or find anybody or reach out to my colleagues who may have more knowledge, or if I don't know of somebody in a specific area. But yeah, you don't have to come down to Florida. And if you have any questions, you can call me. I spend half my day on the phone talking to prospective patients or patients who are not prospective, but they're just curious about whether this is something that can help them and they're just looking for information. You can call me and ask me any questions that you have or any concerns that you have at any point.
Okay, I'm going to ask you for your number now because
Sure.
I might as well put it out there so these guys can write it down.
Sure. The number here is 941-213-4444.
Okay, great. Okay, what are the advantages of, I mean, you've already explained some of this, ketamine over opiates. Opiates are probably better for certain types of pain, I'm assuming, but not as good for other types.
Sure. So absolutely, opioids certainly have their place. Um, the concern with opioids is usually, increasing tolerance, having to increase the dosing. Patients who have been on opioids for a long stretch of time are going to have a hard time weaning off and coming off. Again, ketamine is not going to be as helpful for certain types of pain conditions. There are pain conditions such as CRPS for patients who have been taking opioids to treat this. Their pain levels actually increase with opioid administration. They get upregulation of receptors over time. So for patients that can who respond to ketamine, a lot of times it becomes a lot easier to get them weaned off of the opioids. Number one, because you're effectively treating their pain, so they don't need to necessarily take the opioids to help treat their pain. And there's some research going on now that actually shows that the withdrawal of opioids while patients are undergoing a course of intravenous ketamine, the withdrawal becomes a lot easier to tolerate and a lot less. So um, it may be easier to speed up the actual weaning of opioids and decrease the amount that they're taking or get them off completely, having gone through or concurrently going through these intravenous ketamine infusions.
Without names, of course, can you give us a couple of extreme success stories that you've seen?
Well, I think one of the success stories was a young lady that you interviewed the other day.
She's on here
Becky
now.
John.
Yep.
What's that?
She's
Yeah.
on here now watching us.
Oh, Becky's on. Hi, Becky.
Yeah.
How are you? We've got a large number of patients who either came to us with a diagnosis of CRPS or I made the diagnosis of CRPS. Patients who have had issues with Lyme disease and they develop patients with Lyme disease, probably 80% of them will develop CRPS at some point and vice versa. 80% of the CRPS patients that we treat, if you look deep into it, will get diagnosed with Lyme disease. And gotten off opioids, have improved their functionality, their daily ability to do what they need to do, run errands, quality of life improves. And so, like I said before, the patients that we're seeing, this is not their first stop generally, and they've struggled and they've suffered. And when we see that we can get them back to at least some portion of their life that they had before and enjoy the things and are capable of doing the things that they have before, both for the patients that we treat for these chronic pain conditions, but also from a mental health, perspective. A lot of the patients that we're treating for depression, anxiety, they can't get out of bed in the morning. The thought of leaving their house, proper hygiene, is terrifying for them. They have, they're just trying to survive day to day. And when from the first infusion to the sixth infusion, you can see it in their face. They become alive again and they're looking forward to doing things again, seeing family members that they've kind of shut out for a long period of time. It's the most rewarding thing that you can imagine.
So do you think the patients that come to you that are diagnosed with Lyme disease have Lyme disease, or do you think that they just have this pain syndrome and they really don't have Lyme disease at all?
So that's a great question. And honestly, we get referrals and we get calls from patients who have been diagnosed with fibromyalgia. And fibromyalgia, for everybody out there who's not really 100% clear on what it is, it's basically just a widespread pain condition that is a diagnosis of exclusion. They've typically been worked up for autoimmune issues, chronic fatigue syndrome. They've had the whole $1 million workup, and nobody can put their finger on it. And there's widespread pain, generally muscular, deep pain, and it comes and goes during the course of the day. And certain times activity improves it, and sometimes activity makes it worse. There's typically brain fog or cognitive changes that go along with it. And the majority of these patients are also dealing with major depression and anxiety disorder. To me, fibromyalgia is really a diagnosis of Lyme disease until it's ruled out, because I think that Lyme disease goes very, very underdiagnosed. And we have patients who will come to me and they've been to pain management and they've been to primaries and specialists, and I'll ask them if they've been worked up for Lyme disease, and they'll say, I think so, maybe, probably. And lo and behold, they get diagnosed at that point with Lyme disease. So, it can be chronic pain is a confusing thing a lot of times, and everybody's perception of pain and the way they go about things is obviously different. And sometimes it gets very frustrating trying to treat patients who are dealing with chronic pain. But yeah, I do believe that Lyme disease exists. It's real, and it's not just in Connecticut. And it can cause a significant, it can be very debilitating for a large number of patients.
Okay, so there's a question about how far apart are the sessions scheduled?
So the way that we treat mood disorders and the way ketamine is thought to work for chronic pain are almost opposites of each other. We will typically do 6 initial infusions for patients that we're treating for mood disorders, and we try to do them within a 2 to 3 week time frame. So patients will come in either twice a week or 3 times a week over either 2 or 3 weeks. When we're treating patients with a chronic pain condition, we start off generally with 2 infusions, and we see if the patient responds. If there is absolutely no response after the second infusion, I tell them the likelihood of ketamine helping with their chronic pain is very small. For patients that have a good response after the first 2 infusions, when it comes to treating these chronic pain conditions, a lot of times the more ketamine, the better. The more that they're able to tolerate, the better the ultimate response is going to be. And so it's generally pushing the dosage, especially for patients with CRPS, as high as we can get it safely. And we try to do these infusions on consecutive days. The whole idea is to really shut this whole pain pathway cycle down for a period of time and let it just cool down, give it time to kind of reset itself. And most of the time for patients that we have success with over the 2 infusions, we'll go on and do another 2 or 3 infusions, and at the highest dose that they'll tolerate. And that seems to yield the best response for the longest period of time.
Do people have to worry if they're on other medications when they come in?
So for the patients that are undergoing these infusions for mental health, the idea is higher dose. This is not theoretical. Higher doses of benzodiazepines. So when I say higher doses that are taken chronically, I'm talking about 1.5 to 2 milligrams per day of Xanax or Xanax equivalent. Lamictal, which is a mood stabilizer, doses greater than 150 milligrams to 200 milligrams a day. These medications are thought to interfere with the antidepressant effects from ketamine. So for patients that are taking higher doses than that, I try to be as realistic with them as possible. And the problem with trying for these patients to try to wean down in a short period of time is that the benzos, especially, the withdrawal can be very dramatic and very, very, it's a serious issue and a serious concern. And so it's difficult if you're taking 3 or 4 milligrams of Xanax or Klonopin a day. The question is it worth going through this and having less of a chance for an effective outcome than trying to wean down and then, figuring out, am I dealing with withdrawal? What we want is a good baseline from infusion to infusion. And if patients are having any issues with withdrawal, well, that may manifest as more depression, more anxiety, suicidal ideation. So it becomes a balance of trying to find the most effective way to treat them, keeping them maybe on a higher dose of the benzos and seeing if we can make some kind of a breakthrough, or is it worth taking more time in conjunction with their psychiatrist and coming down on the dosage to maximize the chance of a better response. As far as those are the two main concerns for me as far as treating mental health care patients. The majority of the other medications, antidepressants and other classes of psychotropic drugs, there's really very, very little, if any, interaction with the ketamine, and certainly no adverse effects that you're going to see. For patients who have been coming in more for pain, we're always, even though ketamine does have very minimal respiratory depression, for patients that are taking higher doses of opioids and muscle relaxants, I have them avoid taking them the morning that they do come in for an infusion, only because we're not looking for more respiratory depression or chances for any hemodynamic changes during the course of the ketamine infusions. And the doses for treating these pain conditions are generally 15 to 20 times what they are for treating these mood disorders. And so, ketamine is a very safe drug, and it also needs to be said that it's still an anesthetic, and it still does cause some changes. And for patients that are taking other sedative type medications where you may get some compounded effect from it, we need to be aware of that.
What about lupus?
So we do get calls from patients with certain autoimmune issues, and again, we've treated patients who are having significant pain issues with lupus and with rheumatoid arthritis, and it's difficult for me to say. I would say it's probably 50-50 patients who have responded and patients who haven't responded.
Okay. So you just don't know until you try.
You don't know until you try for a lot of these conditions. That's right.
But in my mind, if I was suffering from pain, I think 50-50 would be worth a risk.
I couldn't agree with you more.
I mean, because if it works, then
yeah.
Is your pain gone? I mean, is it just gone? Or is it just manageable?
It depends. For some patients, the pain is completely gone. And for other patients, the pain level is down 20%, and they're elated by that. If I ask the majority of patients that we're treating, they're walking around with 8, 9, 10 out of 10 pain every single day. And if you tell them, hey, I can't tell you for sure that this is going to alleviate your pain completely, but I think it's realistic to think that we can get it down to a 5, 6, sign me up. They couldn't be happier.
Right. So Janet's question, and this is a good one too, is if I'm on 3 antidepressants and they're not working anyway, and I come to you and the ketamine does work, can I stop taking the antidepressants?
We have a large number of patients who that is their goal, to come off the antidepressants. I tell patients not to stop anything before starting the infusions, because we need a good baseline. And again, all of these medications can cause some degree of withdrawal.
Right.
And in order to not cloud the picture from observing what the response is from one infusion to the next, I have them stay on everything that they're on prior, again, with the exception of the benzos or maybe lamotrigine or lamictal. And if the goal is for an individual patient to come off their antidepressants once they go through these infusions and we know we've had a good response, then in conjunction with whoever is prescribing those medications, and one by one, I think it's very realistic to assume that would be that could be accomplished.
I have one more question for you, and
Sure.
then I'm going to let you tell these people whatever you want. But what is the difference between, this is specifically for depression,
okay,
between IV ketamine and the nasal form?
Well, I'm glad you asked that question. So the majority of studies, the initial studies that were done using ketamine back 20 years ago, were all done with intravenous ketamine. Of course, I'm partial to intravenous ketamine versus other routes of administration, and I'll explain why. With intravenous ketamine, when you inject 50 milligrams of ketamine intravenously, 50 milligrams is actually getting to the brain. We know for sure that it's 100% bioavailable. It's not getting metabolized in the liver. It's not, it's not having to diffuse through mucous membranes or nasal membranes. And there can be a wide variation in what somebody, you, me, and 5 other people can all take 50 milligrams of a nasal spray, and we're all going to absorb different percentages of it. I may absorb 70%, you may absorb 50%, someone else may absorb 30%. So it's very difficult to try to pinpoint an exact responsive dose when you're using a nasal spray. If somebody has bad allergies one day, or they've got nasal polyps, or they have turbinate issues in their nose, it's going to affect how much of it they're absorbing. So that's the first thing. With intravenous ketamine, we all take the same dose. We know what that dose is and what that effective dose is. If you don't respond to that dose and we increase it the next time, we know that increased dose is exactly the dose that the patient is seeing. So when we ultimately do see a positive response at a certain dose, that's replicatable. We know that that patient responded at that specific dose. With the nasal spray or with these oral ketamine, there's no way to try to figure out a precise lowest effective dose, because everybody absorbs things from the digestive tract differently. Everybody metabolizes their liver to varying degrees. Everybody absorbs through their nasal mucosa or their oral mucosa. So just from a precision standpoint, I think intravenous ketamine it's by far the gold standard for how we administer ketamine. Having said that, when we treat patients with intravenous ketamine, if a patient becomes uncomfortable for whatever reason, they become dysphoric or they get uncomfortable with the dissociation, we simply turn the infusion off, and within 2 to 3 minutes, they're back to being grounded. And we simply start the infusion up much slower. Maybe we give a sedative so that it smooths out the rest of the infusion or the experience for them. In contrast, when you take a medication nasally or orally, you're basically married to it until it's metabolized from your system. There's no antidote for it. You can't turn it off. So good or bad, you're going to go through that experience until the experience is over. So for patients, like I said, who have been through pretty horrific traumas and they don't want to take a chance on being taken back to those periods and those horrific times, it's much easier to control the setting and the situation and the experience using intravenous ketamine. So for those reasons, I'm extremely partial to intravenous ketamine.
Is ketamine all you do at your center?
Ketamine was all we did initially, and now we really, by patient demand, we've been doing medical cannabis or medical marijuana certifications for certain patients who meet the criteria as far as Florida state law goes. And really, our ketamine patients were the ones who asked us if we could do that more as a favor to them. A large majority of them have trouble sleeping, like a large number of us all out there. And the medical cannabis seems to, when you get a good night's sleep, it seems to make everything better. For certain anxiety type situations, I think it can be very valuable. So yeah, that's the other service that we do provide here. Probably 5% of the practice is directed towards that, and 95% of it is directed towards the ketamine infusions.
Okay. What would you like to tell anybody who happens to watch this video about ketamine?
What I think I'd like the take-home message here to be is the patients that we're treating are patients that have not had success in dealing with whatever conditions they're dealing with, whether it's pain or mental health condition. And when we first started doing these ketamine infusions here, when we opened the practice 7 years ago, I would say probably 95% of patients were self-referring. They had been struggling for years. They came across ketamine, and a large number of them would say to me, yeah, I have a psychiatrist, but please don't let them know I'm doing this. I mentioned this to them and they thought I was crazy. That's vitamin K, that's abused. There's a stigma to it. So, you know, if you could avoid letting them know that I'd like to do this or I'm going to go through with this. And so patients who are struggling or are looking for options, they're going to, the internet is an easy way to find out things nowadays. And I would say the thing that's become most impressive to me is over time, probably everything is switched. We're now probably getting 80 to 85% of the patients we're seeing are getting referred by mental health care providers. And so whether patients have gone back and said, you're missing the boat, you know, I've been struggling for years. I've been on 20 antidepressants. You know, this is real. This is not, you know, there's research behind this. And so what I would say is be your own advocate and ask questions. And, you know, if you're not getting the relief or the help that you want, don't lose hope. Don't fall into a state of, you know, despair where there's always going to be some other option. And for a lot of patients, it will be ketamine, or it could be ketamine when nothing else has helped. But if it's not ketamine, it will be something else. So pick up the phone and call and see what else is out there, and don't lose hope. There is an answer for you, and you may not have heard of it yet, but 7 years ago, a lot of people didn't know about ketamine. And I can tell you that a lot of patients that were struggling and oftentimes for years or decades are leading fuller, more fulfilled lives now. And, you know, there's always going to be something else out there. So just keep looking, keep asking questions. If you're not getting the answers from the providers that you're having, find other resources and look for other people who are willing to help.
That's great advice. And I think, you know, since I've started doing these interviews, that's what I'm finding is people are they're just not getting the help they need.
Yeah.
And sometimes you have to be your own advocate and try different things. And when I heard Becky's story, I mean, you know, that's about as intense as it gets.
Yeah.
So I want to thank you very much for coming on here.
My pleasure. And thank you for giving me the platform.
And I will put your number down in the description section of this video so people can get a hold of you.
Great.
And you are at the Reichbach Center in Florida, right?
Sure. That's right. Sarasota.
Sarasota, Florida. Okay. Thank you, doctor. It was a pleasure.
Thank you so much. And everybody have a good night.
All right. Bye, everyone.
Bye-bye.
Okay, I want to thank you all for being here. That was a wonderful interview. I hope you guys learned something from it. And I will be back very soon with another interview. My name is Pharmacist Michael. Be happy and be healthy.